Dr. Fischer is a friend and colleague of mine who I've worked with, and so I invited him to give this talk, knowing the impact that his work has had recent years, and so I'm delighted to introduce him. Dr. Kyle Fischer is a clinical associate professor and the director of the Health Policy and Leadership Fellowship Program at the University of Maryland School of Medicine in the Department of Emergency Medicine. Broadly, his interests focus on novel approaches to emergency department-based public health interventions and their intersection with public policy. He works extensively in the field of violence prevention through the Health Alliance for Violence Intervention, where he serves as the policy director. And his health policy work is grounded in considerable experience in legislative health policy. He has previously held positions in the Wisconsin and Maryland state legislatures, as well as the United States House of Representatives Energy and Commerce Committee subcommittees on health. And he is here to talk to you today for our grand rounds. So thank you very much, Dr. Fischer. Over to you.
Thank you, Erin. I appreciate this. And it's good to be amongst friends. And yeah, Erin and I have worked together in violence prevention for over a decade now, which sounds crazy. And so I'm excited to be jumping in a little bit today. So yeah, for folks that I haven't met before, I've been working in the gun violence prevention space for a while now and helped launch the one of the hustle-based violence intervention programs out of Prince George's County. I do a little bit of work with the shock trauma violence intervention program, although they run themselves. And so I've been really doing this work for a long time. And I thought now was a really timely period to cover this big Surgeon General advisory that came out earlier this year. So in June or July, I think it was, the Surgeon General released a public health crisis in America examining this. And so I thought we would examine that today and look at what's in it, what's not in it, and really highlight this pretty seminal document. So goals today are pretty simple. We're going to go through the advisory. So the three big kind of buckets that you can imagine that it takes is we're going to describe the epidemiology of firearm injury in the U.S., explain the health impacts of it, both on individuals and the communities that they live in, and then identify some evidence-based firearm violence prevention strategies that kind of encapsulates what the advisory does. Before we get into it, I got to set a little bit of a ground rule when it comes to talking about quote unquote gun violence, in that gun violence is not one thing. It may get set all lumped together when people talk about it on the news, but in reality, we know we're talking about a number of different distinct diseases, really, that have kind of a common pathogen, right? The firearm. So suicide, community violence, intimate partner violence, legal intervention, mass casualty incidents, accidental trauma. These are all very different phenomenons. The common denominator is the firearm, but as public health professionals, you all know that how you address suicide oftentimes is very different from how you address community violence, which is different from police shootings. And so when you put that all together, there's no single face of gun violence, right? It affects all of us, and that's why public health is so powerful, because when we look carefully, we can detect patterns and go through our public health process and start saving lives. So, all right. With that, let's get into the advisory itself. So this is what it looks like, right? So it's about roughly a 40-page document. And to the start, we need to be very clear that we're talking about a Surgeon General's advisory as opposed to a Surgeon General's report. And now when this came out, the Surgeon General and his team was really making sure that they were very, very clear about that with everyone, because if you think of the Surgeon General report, that is kind of like think of tobacco, right? That was, I don't remember how long it was, but it's like some 500-page document, super thorough, really covers everything, whereas an advisory is a little bit different. They spell it out specifically, and they say, and I think this is worth reading actually, a Surgeon General's advisory is a public statement that calls the American people's attention to an urgent public health issue, and advisories are reserved for significant public health challenges that require the nation's immediate awareness and action. But this document is not an exhaustive review of the literature. The advisory is developed through a substantial review of the available scientific evidence, et cetera, et cetera. So the way of saying, this is the Surgeon General's way of saying, this issue is really important, we should cover it. But this isn't a full report of saying everything you could possibly do to do it, where it's really kind of lifts up some focus areas that I think you could say the Surgeon General thought were important areas to raise up, but it's not exhaustive. So, all right. The scope of it, it's broken down into 4 sections. So firearm violence in the US, death and injury. Also, I'm going to call it the EPI section, the collective toll of firearm violence exposure in the US. That's kind of the effects on people and communities. Contributing factors to firearm violence, aka risk factors, right? And then public health approach to firearm injury and violence prevention. So that's kind of covering solutions. Those are the 4 big things in it. I do want to say kind of at the start, I'm doing my best to really lay out what's in the advisory, and sometimes I tried to take most of it directly from the advisory itself, but sometimes I'm filling in the gaps with other information that is out there in the public domain or in the violence prevention field. So it's got some extra information filled in with it. It's not just running through the document on its own. And I will say too, the advisory, it focuses on specific areas. So if you do read it straight through, sometimes it feels like it jumps around a little bit. And if it feels like my presentation is jumping around a little bit, it's because I tried to stick to the advisory itself, but it jumps around a little bit. So doing my best to balance the 2. So, okay. So let's get into the first section. Firearm violence in the US, death and injury, aka the epidemiology section. So starting out, this is the CDC data on firearm deaths in the US in the most recently available year, which is 2022. And you can see right at the start, I think a lot of folks that aren't in the gun violence prevention space sometimes find this really surprising, that suicide is by far the #1 cause of death by firearms in the US. So in 2022, there were 27,000 individuals that died by suicide with firearm. Homicide is #2 at 19,651. And then you can see some of these other areas like unintentional legal intervention, which is the CDC's way of talking about law enforcement involved shootings, and undetermined are really, really small numbers, right? So the vast majority of homicides, right, most of these are community violence. Now, the numbers we have for it are not perfect. And we're going to get to this a little bit later, but the data systems that we have to track firearm injuries in the United States are insufficient and incomplete, and frankly are not up to snuff compared to other medical diseases, but they are what they are. Within homicide, right, the challenging part of even in interpreting these numbers is we know that there are subsections, and these subsections have overlap too. So for example, within homicide, we have community violence, which that is the vast majority of these deaths. So community violence is probably 15,000 of these roughly 20,000, right? But then mass casualty shootings are part of this. Mass casualty shootings are a small percentage. They're estimated to be 1% of firearm deaths. So it's a very, very small amount. And then obviously, if we're just marking things as homicide, it doesn't get towards intent. So things like domestic violence and intimate partner violence are also a subsection of it, smaller than community violence, but real. And so that is a portion. And I'd also say that some of these Venn diagrams of overlap can make it tricky, right? Because one of the most commonly used definitions of a mass casualty shooting is a shooting where there are four or more individuals that are killed or injured. And that happens with intimate partner violence, right? Where someone may shoot their partner as well as other family members themselves, and that could get categorized as mass casualty shooting. Or, we know in Baltimore, we had our own mass casualty shooting that was based out of community violence, right? So these numbers, there's some overlap, and they can be a little bit hard um, to sift through because unfortunately the data systems aren't perfect that we have in the US to track. We do know, like I just mentioned a second ago, that mass casualty shootings really, they are a small subset. They're only about 1% of firearm related deaths. But I think as public health professionals, we should all be really, really careful. And it can be really tempting, when people bring up mass casualty shootings to kind of, I don't want to use the word scold, but a lot of people say, oh, that's not what we need to pay attention to because that's not where, all the deaths are. And it's true, that's not where the all of the deaths are, but it has a huge collective impact on our society, right? People change their behavior, they're scared. I'll show you some data a little bit later about how sometimes, kids are afraid to go to school because of it. So it's still, these deaths are tragic, and we still need to work towards eliminating mass casualty shootings. But it is important to know that if we want to make the biggest impact and save the most lives with gun violence prevention, that focusing on mass casualty shootings isn't where most of the deaths are. Sadly, when it comes to all of these deaths, we are seeing shifts over the last decade or two. And so this next graph that I pulled out is directly from the report looking at pediatric causes of death. And so the red cause is firearm deaths. And as I'm sure most of you have heard now, gun violence is the #1 cause of death for children. And that blue line at the top, that's motor vehicle collisions, car crashes. And you can see that in about 2019, 2020, that's when firearm deaths in kids surpassed car crashes. So, it's a really sad trend that, even if you look at the red line for firearm deaths in kids, it's been steadily going up since 2013. We're not just talking about a single pandemic related cause here. This is something that's been going on longer than just the pandemic. Unfortunately, pediatric cause of death isn't the only trend going in the wrong direction. This is another graph I took directly from the report looking at firearm-related suicide. They report that across all age groups, unfortunately, starting at age of 10, firearm deaths per capita for suicide have increased over the last 10 years. Now, I do want to, do the caveat with this graph is we are, since the year is ending in 2022, it is capturing that surge of firearm deaths from the pandemic. And so long-term trends, how much of this is pandemic-related spikes versus long-term effects that are independent of the pandemic isn't quite as clear, but still, we don't want to see our numbers going up, let's be honest. All right. And then kind of the other big part of the epidemiology that we're looking at is it's important to know about disparities, right? There are huge disparities in firearm deaths. And the biggest disparity is black and white for the most part, right? So the for firearm homicides, unfortunately, that disproportionately affects Black men. And for all races and all ages, the firearm death rate is homicide rate is 6.2 for 100,000. And for Black persons, it's 27 per 100,000. Now, I take a little bit of umbrage with the way that the Surgeon General reported these numbers, because I think it actually is minimizing the problem a little bit. Because if you look at it, they took gender off the table, because we know that for Black men, it is higher than Black women. So this rate of 27 compared to 6.2, for Black men, it's even higher, right? Similarly, for white men over the age of 45, firearm suicide disproportionately affects that population. And I believe they did a similar thing for how they reported the suicide death rates as well, where it put both genders together. Whereas we know that for firearm suicide, that it disproportionately affects men compared to women. So we have these big disparities based on race. The other thing that I'll mention a little bit later is there are geographic differences as well. We know that rural areas have higher rates of suicide, and urban areas have higher rates of homicide. Okay. All right. So moving on to kind of the next section in the report is, I think they did a really nice job of laying out what they call the collective toll of firearm violence exposure in the United States. And, I think big picture, what you should think about with this is that with every shooting, there is a ripple effect. And it affects much more than just that one individual person. But let's start with that individual person and then start working our way outward. So what I hope everyone really internalizes, and this is something that, as someone that works with a lot of survivors of gunshot wound victims and launched a violence intervention program, one thing that we know very intimately in the violence prevention community is that trauma is just exceedingly common in violently injured patients. And now, I think some people may be hearing that and saying, well, no doubt, right? Like, of course, people that get shot are going to have post-traumatic stress disorder. But it's not a no doubt, right? If we think about the way that we talk about trauma in the United States, we imagine almost that this is a disease of soldiers. We talk about PTSD with our veterans, we talk about it with people coming home, and we think of it as like this Afghanistan, Iraq, Vietnam phenomenon. But, as I like to say, the human brain does not differentiate between a gunshot wound in Baltimore and a gunshot wound in Afghanistan. It is the same threat to your life and activates that same neurologic systems in our brain. So PTSD rates after injury are about roughly 80% 1 year later. So we know it's very, very common. But unfortunately, trauma tends to cluster. And so we need to talk a little bit more about how it's more than just the trauma from this one gunshot wound. So let me briefly make sure I'm being clear about what I'm talking about, right? So in this perspective, we're talking about the small t traumatic experience definition of trauma, which is an event or series of events that is physically or emotionally harmful and has lasting effects on an individual's mental, physical, or social or spiritual well-being. So, right, this is getting at our ACEs, our adverse childhood experiences, our experiences with abuse, neglect, household dysfunction, other things that people may have experienced prior in their life or currently right before the gunshot wound or after the gunshot wound. We know that trauma clusters. And there's a wealth of data that shows that these folks that have been shot, they do not have the same risk profile as the general population. And in fact, when you look at the research literature on people that have survived firearm injuries, there's what I call the trauma divide. I call it the ACE score of 4. It's been fairly consistent when you do studies of individuals that survive a gunshot wound. their ACE scores are much higher than non-survivors. And if you go to the CDC's website, like right now, and you look at their website for adverse childhood experiences, there's a pie chart on there, or at least there used to be. And the way it shows is it says, okay, amongst all Americans, X percentage of people have a score of 0 to 1, X percent have a score of 2, X percent have a score of 3, and then something like 10% or less have a score of 4 or greater, right? And remember, the score goes up to, I think it's 10. It's either 10 or 9. But it's very clear in the literature that survivors of gunshot wound, they usually start at an ACE score of 4. And that is in contrast to the general population. Remember the CDC, they said, oh, just 4 or more, that's high. But the survivors of gunshot wounds are starting out at high and getting to really, really, really high. And so there's an immense amount of trauma that preceded the traumatic event and then gets included with it, right? So you can almost say that they have an ACE score, that their trauma score would be 5 if you just added their personal gunshot wound, although then it's not childhood. Anyways, so that is such a big driver of it. And this trauma really affects things downstream too. So one part that the advisory comments on is some of these side effects. Many of them are related to these traumas. So unsurprisingly, pain disorders in folks that survive a gunshot wound, those more than double, so 117% increase. And then substance use disorders, big increases as well, 144% increases. And I do kind of want to walk through that just a little bit on the substance use side, because it makes a lot of sense. And it's something that we can put our hands on, and we have room that we can make an effect on. So keeping in mind that, I just told you that 80% of survivors of gunshot wounds have some degree of post-traumatic stress. Also remember that in many of the urban communities where community violence is the most common, which is most of the folks we're talking about here, there are mental health deserts, right? So no one is getting professional help, or a minority of people are getting professional help for signs and symptoms of post-traumatic stress disorder. So if you think about it, some of these symptoms that people experience, right? Like, I feel anxious, I'm on edge, I've got my head on the swivel. There is a legal, easily available substance that you can purchase in Maryland through regulated agencies called cannabis that is commonly used to self-treat all of those things. Similarly, for people that with their PTSD, they have trouble sleeping at night, which is a huge percentage of people, actually. It is one of the most common symptoms of traumatic stress that people experience after firearm injuries. That insomnia, common way to treat insomnia is alcohol, right? And it doesn't take much for having a couple of drinks at night to 3 to 5 to all of a sudden we start thinking about tolerance, dependence, and addiction. So these are not unexpected things that happen. Okay. And then the other thing that we need to throw into this mix on these effects on survivors. And now this next slide, I can't unpack the association versus the causation. So let me be 100% clear on this, but we know that one of the biggest risk factors for being shot is if you have ever been shot before. And unfortunately, these re-injury rates are exceptionally high, very, very high. And so this is a graph that I made a few years ago. I should probably update it now, but it was a systematic review that looked at 19 studies looking at the rates of recurrent violent injury in survivors of community violence. And if you look at that median, it's coming in around 25 to 35%. Fairly safe to say 25, 30%. That's really, really high. Just imagine that if we had um, a rash of heart attacks in young, previously healthy 25-year-old males. Pharma would be rushing to it, the CDC would be rushing to it, the NIH would be rushing to it. It would be the problem to solve of the decade. But unfortunately, that has not been the strength of the response that we have seen with survivors of gun violence. But we know that this is a huge risk factor for folks that whether or not it's all association of, someone that's at risk of getting shot once is just at risk of getting shot again versus this cycle of violence where if you get shot once, then there may be retaliation setting up for more retaliation. It's impossible to like totally untangle that. So that's why I put that here. And then I do want to raise, I think this is my favorite part of the entire Surgeon General's advisory. This is a direct screenshot of one single entire page that for folks that are interested in checking it out, I think it's a very, very powerful data visualization that I wanted to raise up. Just laying out these cascading harms, right? And if you look at that top red dot in the screen, those are the people that had lost their lives to firearms, those 48,000 people that we mentioned before. But then there's this waterfall effect where underneath that, we know that for every one person that dies from a firearm injury, many more are injured that non-fatally. We actually don't know the exact numbers of non-fatal injuries in the United States, but we know that it's 4 to 10 times higher than the numbers of deaths. Then on top of that, there are people that witness injuries. So if you look at the right side of the screen, the Surgeon General offers some color on what this means. So mothers that witness a shooting in their community are 60% more likely to meet criteria for depression. Then there are the family members that have lost loved ones, parents, children, brothers, sisters, and we know these, for example, siblings of kids that have died from firearm injuries have higher rates of psychiatric disorders. Then it gets to, right, our bigger communities, right? Schools, workplaces. We have over half of US teens are worried about school shootings happening at their school or school near them. And then the collective trauma and fear, like I mentioned before, about these mass casualty shootings, they have this outsized effect on our communities, but despite being a small number. So the general public is feeling this and changing their behaviors in ways where sometimes people are feeling afraid of going to a concert, right? The largest mass casualty shooting in America was in Vegas at that music festival. So these effects really do waterfall and cascade out. Okay. All right, so the next section in the document is on the contributing factors to firearm violence. I'll admit, and I'm trying not to do too much criticizing or critiquing of the advisory, but I thought this was kind of a pretty slim section in it. It actually was only like 2 pages long. They didn't list that much, but they mainly focused really on poverty and geography in their description of it. And poverty and low income being across all forms of gun violence being a risk factor. Geography, like I mentioned before, community violence tends to happen in cities, whereas suicide tends to happen in rural areas. And so you can see kind of some of these big picture disparities. The other factors that they focus on quite a bit is the numbers of firearms themselves and the storage of firearms. The numbers of firearms in circulation in the United States has gone up in the most recent decade, and I actually if you wait just a minute, I'll tell you a little bit more about that. And in addition to that, we know that people are not storing firearms safely. So the presence of firearms, we know, is an independent risk factor. And in fact, this goes back way back in the day to some of you may recognize this particular article itself. This was published in the New England Journal of Medicine in the early 90s. This is the famous Kellerman study that aimed to look at whether or not the presence of a firearm in the home was protective against intruders or a risk factor for suicide or intimate partner violence. And it found out that, in fact, a firearm in the home is a risk factor for being a victim of gun violence rather than a protective factor. This is the paper that created the so-called Dickey Amendment that created a couple of decades of de facto ban on federal funding for firearm injury research at the CDC and later the NIH. So why is this a risk factor? I mentioned before, having a gun is a risk factor for DV, IPV, that side of things. But for kids in safe storage, we know that kids get into guns, and it's a risk for accidental injury and suicide. And the Surgeon General, I really thought that they laid out this in a very visual way that I thought was really effective, in that we know that safe storage oftentimes is not happening. That's a huge risk factor for kids. And in fact, so of the unintentional deaths that happen among kids and adolescents, over half happened in their home. And of these, about 3/4 were loaded and unlocked. And the most common places that you can find them for kids are in places that I'm sure you all in the public health community are looking at this picture and causing you a little bit of a headache. The nightstand, on the bed, under a pillow, under a mattress. Obviously, these are not safe places to store firearms, but these are the most common places that they're being accessed when kids are dying. And then on top of some of these risk factors, we did find big COVID-19 effects. So COVID-19 exacerbated known social drivers of health, social determinants of health across, and we saw nationwide increases in firearm violence in the country. We know that there was a disproportionate impact on marginalized communities, especially Black and Brown communities and poor communities. And then on top of that, there was a surge in firearm ownership in the US during the pandemic, and a large proportion of them were new firearm owners. So 5.4 million Americans became new owners during the pandemic. Okay. Then I did want to say, this is an area where it being an advisory and not a report, it left out a lot of things in it. So it left out things like the built environment, the effects of lead toxicity during childhood development and later on risk, the availability of alcohol, the availability of a social safety net. We know that insurance expansion decreases rates of firearm violence. So there are tons and tons of these different factors that were not included in it, but I thought I wanted to at least mention for you all. Okay. And then this is where they jumped into the public health approach to firearm injury and violence prevention, aka solutions. This part of the advisory, to be honest, it felt a little bit like a laundry list. There was a lot of bullet points and not a lot of data, but really good to get some of that information out there. They started out talking about just the importance of adding critical research investments. Like I just mentioned to you before, Congress passed something called the Dickey Amendment during the 90s after Dr. Kellerman published that paper. And firearm violence funding has fell off a cliff for decades and is only barely starting to recover over the last couple of years. This is a graph from a really phenomenal paper that was published a few years ago. I believe it was in JAMA. I'd have to double check. That looked at the burden of the disease based on mortality compared to the federal government research funding. And as you can see, gun violence is at the bottom of that list, where it has roughly the same uh, uh, burden of disease for mortality as sepsis, right? Septic shock, but way fewer funding. And it's important to note that this is a logarithmic scale, right? So if you look at the y-axis, it's not straight, 1-to-1, it's logarithmic. So 0.1 is 10%, and then 0.01 is, 100%. So we're at, over $1 billion for sepsis, and we're in the millions for gun violence. And in fact, to this date, the CDC and the NIH only have $25 million for firearm violence research, that is dedicated for it. So it is not where it needs to be. And so the Surgeon General lays this out a little bit more, talking about the need for better data sources and collections, evaluating short-term and long-term outcomes of prevention strategies, and conducting implementation science research on the programs themselves to decrease gun violence. I put a little logo of the Gun Violence Archive down at the bottom, just as a reminder to myself. For anyone that's on here that hasn't dug into any of the gun violence reporting data and been onto the CDC website, which I'm guessing is probably most of you, it's not good, to be really frank. The fatal data injury, it takes a couple of years before we get it. There's a huge lag. The non-fatal data, there's a big lag as well, and it's not super, the accuracy of it is not perfect either. And so you may see, if you're watching the news and they're talking about how many gun deaths there were this year, they will commonly quote a group called the Gun Violence Archive. The Gun Violence Archive is a nonprofit organization. They do great work. I love them. They're a group they're led by a guy named Mark Bryant, but they are not hardcore academic researchers. In fact, if you asked Mark who he is, he'd say, I'm a Southern good old boy that grew up shooting guns, but thinks that we can do better. And so his program is basically an elaborate system of Google alerts with his group of 10 men and women that he has helping to run this thing. So it is no way to run a railroad. They're doing great work with their team to do our best, but it is not up to snuff for real public health epidemiologic purposes. Okay. And so next, they talk about community risk factor reduction and education. I have here kind of a diagram of some of the most common members of public health programming towards community violence. There's a lot of evidence-informed types of programs, ranging from hustle-based violence intervention programs to street intervention to peace fellowships. So in Baltimore, may be more familiar with Safe Streets, that's street intervention. ROCA, that folks know, that would fall kind of under targeted trauma-informed care because they do a lot of cognitive behavioral therapy, cognitive behavioral intervention. We have our hustle-based violence intervention program at Shock Trauma that Erin mentioned before that she ran for a number of years. So we have a number of them here. The Surgeon General did talk specifically about hustle-based violence intervention programs. So I wanted to just briefly kind of talk about what they are, so you get a flavor of what these programs, how they actually work in practice. What does it mean? I apologize for that. I may sorry, I just almost accidentally skipped a slide. So these different things that they've laid out were the community violence intervention strategies, like I was just mentioning. There's violence prevention and emergency preparedness programs that are kind of like threat identification for people that might be a mass casualty shooter. Then they talk about how systems should educate on safe storage and addressing the structural determinants of health. But I did raise this question of like, if you're not familiar with what some of these community violence intervention programs are, hustle-based violence intervention programs are just one example of it. The technical definition, right, is these programs combine brief in-hospital intervention with intensive community-based case management, provide targeted services for high-risk populations to reduce risk factors for re-injury and retaliation, while cultivating protective factors, right? This very academic definition, but what does that look like in practice? Well, in practice, right, we know if you think of an individual person that's at risk for violence, if you identify someone that's been injured, right, that's a huge risk factor. We, like I mentioned before that people were injured, we have all of this traumatic experiences. The injury itself is both physically and psychologically injurious. And so we know that after the injury, that there are protective factors and risk factors. So peer mentorship is protective, cognitive behavioral therapy protective, addressing all of these social needs and case management needs protective. But once folks get into retaliation, using substances to self-treat, the post-traumatic stress disorder, these can amplify things. So these hospital-based violence intervention programs use a team that is centered around what we call a violence prevention professional, which are these credible messengers, people that are from the community, know the communities, can connect with the patients to go through a process, right? And start out making sure that they're meeting with patients at the bedside in the hospital, delivering high quality trauma informed care, identifying a comprehensive needs assessment for patients, ranging from everything from, do you need health insurance? Do you need food? Are you looking to get back into school or a job? And then you follow through on it and you go upstream and address those social determinants of health. I want to make sure that I get through these last couple of slides to make sure that we have time for questions. So we'll say that the evidence on most community violence intervention programs, I think the collective experience of the academic community is that we would say that they are evidence informed, and that for a variety of reasons, why they're hard to study, more trials would be beneficial. I did my best. I'm working on a systematic review right now, and I plugged all of the results from my table into ChatGPT to summarize my results from this paper that is being submitted as we speak. And so just the very brief summary of all of these new trials is that they collectively demonstrate that many of the interventions were effective in reducing violent re-injury, with some trials showing a substantial reduction in recidivism, or a few studies showed minimal or no difference between the intervention and control groups. So we could talk for hours about the data behind community violence intervention, but I want to say the academically honest answer is that I think most of the community believes it to be an evidence-informed strategy with more data needed to get to where we need to be. But of course, the programs are more than just re-injury or retaliation. So just some patient-centered information. These violence intervention programs have been shown to address mental health needs, get people into counseling, education, employment, address social substance use, and other things like court advocacy and childcare, parental support. So it's more than just re-injury retaliation. Okay, that's my very, very brief part on community violence intervention. And then the Surgeon General does bring up firearm specific strategies themselves. And he specifically, the things that he lined out that said that Congress or states should do are require state storage and child access prevention laws, universal background checks and expanded purchase or licensing, implement extreme risk protection order policies, ban assault weapons in large capacity magazines, create safer conditions in public places related to firearm carrying, and then treat firearms like other consumer products. That's basically code word for Congress should repeal a law that commonly gets referred to as PLACA, which provides immunity to the gun industry um, for adverse effects from firearm injury. So all of these are known firearm strategies that are firearm laws that have been proposed. We have a dearth of research and not enough research on all of these different firearm laws. I will say, so if you look, the best compendium these days on the data behind firearm specific laws is the Rand Corporation has an ongoing project where they keep updating the systematic review. Now they're up to the fourth update of what the data shows for all the different laws. And for safe storage, there's some evidence that it prevents child suicides. For universal background checks, there's moderate amounts um, of data showing that can be beneficial in decreasing homicides and suicides. Extremist protection orders, the data is very limited. There's some newer data that I've seen literally just in the last month or two that is starting to be promising, but it's very early. The assault weapons data is very minimal. I think there are varying interpretations after the assault weapons ban that Bill Clinton passed, but there's a lot of controversy around that. The greater safe conditions in public spaces, there really is limited to almost no data showing that that actually is beneficial. So I do think the Surgeon General may have, that is one area where I think he got ahead of the data. I'm not saying that the policies are unwarranted, but if we're going to be strict hardcore academics about it, that is an area where I think he did open himself up to a little bit of controversy, maybe, although I haven't heard too much from it. Okay. All right. And then the last thing that the Surgeon General recommended was improving access to mental health and supports. So prioritizing increases in trauma-informed mental health resources and enhancing safety measures and mental health resources in learning sessions for children and adolescents. It was very brief. It was like a couple of bullet points. So, all right, it's great. We're coming in about 10 minutes for questions here. So, just my overall impressions of the advisory is I think it was a critical call to action on a pressing public health crisis. They did provide tangible, actionable solutions to what people can do. But I do think there was a missed opportunity for doing the full report. I think there could have been a lot more details and actionable steps that people could have done, especially in areas where it's not as politically popular to take on firearm injuries. I think there was a missed opportunity. I'll be real blunt about that. So let me stop there, and I'm happy to answer whatever questions folks have. I got 10 minutes. Great.
Sure. David Mann in the department and also in the health department in minority health and health disparities as an epidemiologist. And it looked to me when you talked about the gun violence research areas, they were mostly public health surveillance and intervention delivery kind of research. And it seems like that's always less well funded than biologic discovery research and the other diseases at the top of your graph. So I don't know if you would agree with that, but that was just an observation that I had.
Yeah, I 100% agree. The surveillance itself is, yeah, it's underfunded. It's not where it needs to be. The CDC, as we speak, are working on creating a dashboard for more up-to-date surveillance data to be available to people. Their goal is to get it out. The White House wanted it out this summer. They couldn't get it done by then. When I met with folks from the CDC just in the last month, they are still hopeful they're going to get this launched. But as you all know very well, the CDC as a whole, what they're going to look like next year is a big question mark. So my fingers crossed that they get it out the door and get it up and running. All right. What other questions do folks have? Yeah, David, jump right in.
So the other observation I had is your list of steps to take all looked like they were steps that were outside of the traditional role of a health department. It was mostly kind of political, social. And so I think that when we say that we're taking the public health approach to gun violence, it might be important to specify that that doesn't mean the health department can solve it all by itself with no extra money, because I think sometimes that's the assumption people make as someone who works in a health department. And there's massive social forces and political and economic and health and all policies kinds of considerations that have to happen. So I worry that sometimes people think, oh, we'll let the public health department solve that for us, and then they kind of ignore it after that.
Yeah, that's a great observation, and I agree with that 100%. I think that's part of the reason why I was disappointed that it wasn't a full report, is it does require a health and all society type approach to get at it. I do want to make sure I raise up the health department does have a good role though, and in many places around the country, the health department has a really strong role. So in varying parts of the country, it looks different everywhere, right? Every health, if you know one health department, you know one health department. But there are a lot of places where the health department is leading the charge on a lot of the coordination work of coordinating different programs in the city. There are places where the health department is directly funding programming itself. So, for example, I'm working with Monterey County in California right now. They are standing up this huge community health worker program, and in addition to that, part of their community health worker program are going to be, violence prevention community health workers. So there are. I definitely want to make sure that I'm not minimizing the opportunity for health departments, but like you said, it's got to be whole of society. The health departments need more resources and more staff, and you can't do it on your own. And but there's as much room to run as health departments are resourced with and allowed to. Okay.
I have a question, Jack Goralnik in the department. Can we learn anything about possible interventions comparing the US to Canada, where there is quite a bit of gun ownership and much, much lower violence?
Yeah, that's a great question. I left off one graph from the report that looked at the US compared to peer nations. We, unsurprisingly, our firearm deaths are through the roof higher than every other country, especially in peer industrialized countries. It is hard to compare country by country in a lot of different ways. A lot of times people like to bring up, for example, certain Nordic countries. I think it's Israel is the country that I'm thinking of, and I apologize if I'm thinking of the wrong country, where there's very, very high rates of firearm ownership because everyone in Israel, when you're an adult of military age, you spend some time in the Israeli Defense Force. And so it's part of the culture that, people train, so they're ready. There's firearms, but there's a huge critical difference in that firearm ownership where the firearms have to stay on base. So they may be an owner, but they're not taking it home with them. So there are huge differences even if you just look at firearm ownerships. Once you get to the laws and what you need to do for a background check or a license or training, they're just so much different in every country. But our numbers would undoubtedly go down if we enacted the policies of really any of our peer neighbors.
Are there any more questions? We still have a few more minutes if anyone else wants to ask a question.
David, jump in.
So a couple thoughts on some of the data you presented. The one slide that talked about the homicide rate in blacks and the suicide rate in whites, and you talked about how if they had sex stratified it, it might be even more extreme. I would bet if they sex stratified it and then age stratified it, you could get some probably really extreme differences in certain age groups. So just that
Yes.
one point. And then you had the slide that talked about, I think it was 117% increase in pain disorders and 144% increase in, I'm not quite, substance use it was. And I was wondering if that comparison was compared to a group where you've adjusted for the risk factors for the event that also may be risk factors for the outcomes we're looking at.
Yeah, that's a great question. I don't know the answer to it. In other lectures I give, um, I have separate studies that I usually cite, one for alcohol and one for cannabis. And the data actually is pretty clear that a good number of people start using both of those substances after the gunshot wound compared to before. But that said, doing the exact comparison and association of it, is it really 114% or is it something a little bit lower? I'd have to dig a little bit more into it.
Okay. So thank you very much, Dr. Fischer, for all of this information. Hopefully next year will go as well as it did this year. So we can just keep optimism going for this.
The work
Thank you
continues.
so much.
Thank you. All right, take care, everyone.